So the AAP recommends that infants be breastfed exclusively for the first about 6 months of life, and then continued as long as desired by the mother and the infant up to at least 1 year, and then beyond as they want to keep going. So the World Health Organization supports this. They say continue breastfeeding until 2 years of age, and then the Institute of Medicine also supports this. So the reason the 6 month is the point instead of the 4 months is all the studies that are looking at the benefits of breastfeeding as far as decreased illnesses and long-term benefits are based on better outcomes if you make it closer to 6 months than stopping at the 4 months. So that's always a little bit of a issue, because the Committee on Nutrition had originally always said 4 months to start solid foods, but the Breastfeeding Committee said 6 months. So it's kind of a soft thing, but at least by 6 months, everybody agrees you should start introducing additional foods, but continue the breastfeeding until then. Because the longer you do it, the more milk mom's giving, the more benefits everybody gets. So there are lots of definitions regarding breastfeeding that you just need to know, so that when you're reading an article about breastfeeding, you know what people are saying when they actually use these terms. So if you're full breastfeeding, then that means only human milk, nothing else, almost exclusive. You're not really going to use very often, but that might mean you give an ounce of water or something, but nothing else for nutrition. Partial breastfeeding, which we see a ton in our clinic, where you're giving breast milk and an infant formula along with the breast milk. And then the high, medium, and low are just based on how much additional foods or milks the infant is getting. And then the never breastfed is self-explanatory. So the contraindications to breastfeeding, there are not very many infant reasons they shouldn't breastfeed. So the classic galactosemia, no breastfeeding because the galactose is in the breast milk. Can't avoid that. Maple syrup urine disease, you could do a tiny bit of breastfeeding, but generally it's easier just not to. In the PKU, you can breastfeed some, and the geneticist just needs to follow the PKU level, phenylalanine levels really closely. But if moms are really gung-ho and determined that they want to breastfeed, then that is one that they can. So the maternal reasons to not breastfeed, so HIV, as long as the replacement is safer. So obviously in the US, it's safer to breastfeed, but if you have unsafe water supply, unsafe replacement feeds, then the HIV is safer to be exposed to. HTLV 1 and 2, we don't encourage moms to breastfeed in the US, but in Japan, they have had good luck with letting babies breastfeed until 6 months of age if moms have HTLV 1 and 2, and that does not seem to infect the babies if they stop by the time they're 6 months of age. Moms who have TB shouldn't be breastfeeding until they've been treated for 2 weeks, or if the infant's is receiving the isoniazid. And this is one where mom can pump the milk and give it to the baby because the milk's not infected, just the mom is infected, so she can't be around the baby. Same thing for the HSV. So if mom has a lesion on her breast, then she can't be putting the baby to the breast, so she would need to pump and give the baby the milk. And then same things for chickenpox. If mom has exposure or has the chickenpox, then she can give the baby her milk, but she can't be with the baby until the lesions have crusted over. And most medications are okay because most don't get into the breast milk, but for radioactive compounds, chemo drugs, and there are several that you just need to be aware of. Look at how to look up and find if medications are safe or not. Let me see, where's my LactMed? I'll see later. So, because LactMed, it used to have an app that was really good, so you can look up real easily for medications, but they're retiring the app at the end of this year, so it's not going to be updated anymore, but you can still get the LactMed information just by Googling LactMed breastfeeding, and then that comes up on the National Library of Medicine, and we'll give you all the information you need. Okay, and now the AAP has a breastfeeding curriculum, so we're going to go through a little bit of that. There's a lot, they have a lot of little short videos, but I'm just going to show one of them. Kind of goes through the details of the anatomy and physiology of breastfeeding.
To understand breast milk production, let's start with breasts. Breasts consist of fat and supportive structures, glandular tissue, and lactiferous ducts. In the glandular tissue, there are alveoli, made up of alveolar cells or lactocytes that produce milk. Surrounding the alveoli are myoepithelial cells that contract to release milk into the lumen, which transverses through the lactiferous ducts, which guide the milk to the nipple, where it is transferred into the baby's mouth. During pregnancy, the placenta releases human placental lactogen and progesterone, and the anterior pituitary releases prolactin. All three hormones stimulate the growth of glandular tissue and prepare the alveolar cells to produce milk. However, the high levels of progesterone produced during pregnancy inhibit significant release of milk. Once the baby and the placenta are delivered, progesterone levels decrease and milk begins to be released. Initially, the breasts produce colostrum, a thick yellowish fluid, rich in immune cells and antibodies, low in volume, but high in protein. Transitional milk, higher in volume and fat, normally will be present between 2 to 5 days after birth. This can be earlier for multiparous women or delayed for women who have C-section delivery, medical complications, or an infant who is having difficulty attaching and suckling at the breast. The milk then transitions to mature milk in composition by about 2 weeks. The first few weeks of life are critical in establishing milk supply. Newborns may feed at irregular intervals throughout the day and night, often cluster feeding, and having 4 to 5 hours hiatus. At minimum, infants should be feeding 8 to 12 times over a 24-hour period. Feeding times are measured as the time from the beginning of one feed to the beginning of the next. The release of milk involves interactions between mechanoreceptors in the breast, the hypothalamus, the pituitary gland, and myoepithelial cells around the alveoli. When a baby latches and suckles at the breast, it triggers a series of reflexes that promote breast milk production and release. First, the mechanoreceptors inside the nipple sense the baby suckling and send a neurological signal to the hypothalamus. The hypothalamus stimulates release of the hormone prolactin from the anterior pituitary and release of oxytocin from the posterior pituitary. When released into the bloodstream, prolactin stimulates milk production by the alveolar cells. Oxytocin stimulates the myoepithelial cells around the alveoli, causing them to contract and expel the milk into the ducts, a process called the milk ejection reflex, commonly referred to as milk letdown. The initiation of milk production and release primarily depends on the hormones prolactin and oxytocin, so this is termed the endocrine phase of milk production. To ensure continued adequate breast milk production, frequent and effective milk removal is required. When milk remains in the breast, there is a feedback inhibition to continued milk production, and the supply decreases. This more local control of ongoing production at the level of the breast is the autocrine control phase. Frequent, on-demand feeding thus ensures a continued milk supply.
All right, so that's just a little reminder of where we started back in medical school, learning all that. So, and then there are more slides that go through the biology and the benefits of human milk, and then another one that talks about the intake and growth. So if you want to go through those, you can at your own leisure, but it's that same lady's voice. It's kind of slow and it's good information, but it's not very enthusiastic. So the next part of the breastfeeding curriculum is all about patient care. So you want to kind of make sure, let's see, that you got that. So when you have questions about breastfeeding or you're trying to educate parents, if you kind of don't know what you're supposed to be telling them or you can't remember all that you've learned here, the Stanford website has a great section on the breastfeeding information. It's got all these little videos that Jay Morton has done, and it talks about right from the get-go, it talks about later, and it's really good videos about latching and hand expression and pumping and everything you need, and talks about medications and milk. and also storage. And so for the parents who also have to be separated from the baby by like distance, if moms are traveling, it kind of goes through how to ship the breast milk as well. So it's just a really great place to remember if you want some extra help sharing stuff with your families. And you know, with everybody being so good about internet use, it's really handy now because then they can just look back. And here's another website too that's really good, firstdroplets.com, and it lets you even choose if you're having a term baby or a very early baby, and whichever one you click on, then you can go from there and get all the information you need to know. And this also has additional videos. There's kind of similar to the Stanford one, but if they just want something else to look at, it kind of goes through the hand expression and the attachment also, and kind of reinforces everything that we're telling families about the importance of breastfeeding from the get-go. And then our hospital has the designation of a baby-friendly hospital. So we went through the steps that were required 5 to 10 years ago, and it just means that you've met these 10 steps. The hospital has the written policy about breastfeeding. All the staff that worked with babies has been educated about breastfeeding, that the parents are supposed to be informed about the benefits of breastfeeding. The breastfeeding is supposed to be started within 1 hour of birth, and that kind of goes with skin to skin within 1 hour of birth, whether you're breastfeeding or not. All of the babies should be put skin to skin. We try to avoid any supplementation of anything besides breast milk unless it's medically indicated. So it's really important to know when do we need to give milk and when is mom just worried or uncomfortable, and how can we reassure and get past that point. Breastfeeding should be encouraged on demand. Pacifiers should be avoided until the breastfeeding is well established, unless you need them for pain control, then it's fine, and then try to wait about 3 weeks or so before pacifiers are given to the babies. And then keep moms informed on where all they can go for help if they need help after delivery. Let's see, this thing is hard to get rid of this top thing. So the Baby Friendly has a whole website, and it goes through the 10 steps and got all the support and any extra information you want to know. The Office of Women's Health also has lots of information for moms if they need more information about breastfeeding, and they also have a 60-page guide. I thought I had up, but so it's got lots of different information that moms can do too. So many places online that people can look at to see what they need to do. All right, this is kind of a picture of the guide that you can download. And the Office of Women's Health has also done studies just presenting the business case for why businesses should support breastfeeding, to show that it actually is cost effective, because they've shown that for every $1 spent in supporting breastfeeding mothers, they get a $2 to $3 return. And that can be anything as simple as decreased healthcare expenditures because the babies are healthier if moms are able to breastfeed, to decreased absenteeism, so the parents are there, moms are able to go to work and they're not missing all the work time. So then as the last part of the AAP breastfeeding curriculum, just they encourage practice-based learning so that y'all get comfortable learning how to educate and teach others about breastfeeding. So, you know, hopefully when you're in the nursery, when you're in the NICU, you get to take the time and to learn more from the lactation consultants there. And then when you're in clinic, we have had increased numbers of moms breastfeeding there, and so you can take the time there. So it's really important to understand why moms stop breastfeeding, so that you know where your discussion can lead to keep them on track. So most of the time, the number one concern parents have is about their milk supply, whether it's good enough or whether it's even is enough. So you need to be able to say, all right, this is how we know that you're having enough, just simple things they can keep track of at home, like the stools, and that, you know, just reassure her that her milk is great quality and all the benefits that she's getting from it. And then the next reason, most common reason moms quit is when they have problems, either with latching, which leads to then pain, which can then result in skin breakdown and milk stasis, which then can lead to mastitis. So really education about making sure everything's getting done and she's getting the support from the beginning can really help parents breastfeeding. Okay, let's see. Share screen. Is that better now? Okay, good. I wondered that little thing across the top went away. So.
He is at the lecture.
Okay. I don't know. Okay. Hopefully everybody's good. If you're not good, text one of the third years. Text Dalton. He says he really wants to help. So another reason parents say that the babies will stop breastfeeding is when the baby starts to bite. They think the baby loses interest. They think the baby's not just needs more than just the plain milk. So when babies start to bite, that's not a reason that moms have to stop breastfeeding, but moms do need to know ahead of time before they get the teeth, how do you respond when the baby bites? So it's really best if moms push the baby's head toward the breast rather than pulling off, because pulling off is going to hurt mom worst of all, and then it's just going to get the reaction that the baby's going to think, oh, this is fun, I got a reaction out of mom. But if you push the baby towards the mom's breast, then the baby's going to automatically let go, and a couple of times of doing that, no more problems, the baby won't bite anymore. And babies losing interest, often moms misinterpret the developmental milestones that they're awake and aware, and so they just start looking around, and it's not that they're not wanting to breastfeed anymore, it's just that they're discovering the rest of the world. And so then you have to say, okay, now you used to be able to go breastfeed in the middle of Starbucks and it didn't matter because the kid didn't get distracted by everybody, but now you're going to have to breastfeed where it's quieter and there are less interesting things going on, because they really will get distracted and self-wean, but that's not what our goal is. And moms a lot of times think it's inconvenient, and that's where if you can really give them the support for the first few weeks, it can actually be more convenient in the long run because it is so much faster. And then returning to work or school is certainly a tough thing for moms. If they don't have access to a pump, then that's going to make it more difficult. But we try to get them pumps if they need to, so we can get them educated about how to continue. And also residents should always kind of think about, what's your attitude? How do you feel about your knowledge? Do you feel comfortable with giving information about breastfeeding? Okay. All right, so now the AAP has a few little slide sets. We'll go through just this little basic assessment. And all these slides are also online, so if you want to look at them again later, or when you get out in private practice, you want to look at them, it's easy to get them. If you just Google AAP breastfeeding curriculum, you can come across all this stuff. So when you're first seeing the moms, you really want to observe the mom feeding the baby and see how things are going. And if you phrase it as, I'd like to see how the baby feeds, then it's less like I'm judging you, because you're obviously not judging the mom. You do want to see how the baby feeds and see if there are any problems. And you may just notice some things that the mom could do differently to help her. And also, as pediatricians, we're not often super comfortable evaluating the breast. So hopefully the OB has done that more, but then we can at least see how the baby is interacting with the breast. So you want to make sure that mom is comfortable when she's feeding the baby, because if she's awkwardly sitting and struggling to hold the baby up, then that's not going to be good. So there are lots of different nursing pillows you can get. She may just need a chair with an armrest, so that gives her somewhere to support her arm while she's holding the baby. You want to make sure that when she is holding the baby, the head, the shoulders, and the hips are all aligned, and the baby's not straight, and then the head's all twisted, and the baby should be facing the mom. So it's like chest to chest for mom and baby. The infant should be brought to the breast, like move the baby, don't move the mom. And that way it makes it more comfortable, and try to avoid pushing on the back of the head. Just support the baby's neck and then bring the baby in that way, so they just don't do that reflexive arching that they do. So there's several different holds that moms can use. You got the cradle hold, where you just, kind of think about it traditionally, the baby's head is in the crook of the mom's elbow. The cross cradle hold, where you've got more of the neck support here going on. You're holding the baby across the back. The side lying hold, which is super easy, especially this is good for moms who've had C-sections, because they can just lie down, the baby lies right beside them. The football hold is also another good one for mom who's had C-section, and it's just the baby's on the side of the mom instead of across the mom a little bit. with the baby feeder up into the mom's axilla. All right, so then you want to look, once you see if they're kind of positioned well, you want to look at the latch. Mom should hold their breast with a C-hold so they can have a little sandwich for the baby to latch onto. And so you put the 4 fingers underneath the breast and the thumbs on top and just support the breast so that you can bring the baby there. Take advantage of that rooting reflex that babies have. You can stimulate the side of the baby's cheek, and then that'll help the infant open the mouth wide, and then time that open mouth to getting the baby onto the breast, and make sure that that mouth stays nice and wide and open when you put the baby on there. Because you really want a big full mouthful for the baby, because if the baby is just pinching on the nipple, then the nipple is going to be compressed and the milk is really not going to be able to come out. Besides, the mom's going to be really uncomfortable. So just big, wide open mouth, really close to the breast. That baby's face is really up nice and close. And the mom should be comfortable if the baby has a wide open mouth, because the baby then is just going to be gently stimulating the breast instead of pinching. If mom has pain, then she should release the baby immediately by sticking her pinky in the side of the baby's mouth to pull the baby off, so that she doesn't again pull and create suction that makes her more painful. So you see this big open mouth with the correct latch, and then the incorrect, poor little baby's just pinching. Mom's not going to be getting any milk out, so they're all going to be frustrated. And you see the top with the little drawing of the nipple, that it really gets the tongue down underneath the nipple and can stimulate the breast with the massage, and then that'll get the milk out. And then in this picture, the nipple's not being compressed because the baby's mouth is still staying mostly open. So when you're looking, once the baby's on, if you think they've got the big wide mouth, the next thing you want to check, just make sure those cheeks are not sucking in and they're not clicking, making all kind of weird noises, and the lips are curling in. And if the infant's moving around a lot, then something's probably not quite right either. And still, if mom's not comfortable, then that's not good. So later signs, if you pull the infant off the breast and the mom's nipple is super white and compressed, then something probably wasn't going right either. And then obviously if they're not gaining weight well, mom doesn't have good milk supply, then our latch is not so good either. So when you're watching the feed, you've got the position right, the latch right. Now let's check, make sure they're the baby's swallowing, and then you can hear the milk going down. Initially, the babies are going to suck really frequently, but then once the milk starts flowing, then the sucking will slow down a lot and just kind of be kind of periodic as the milk starts coming in, and it'll slow down to about 1 suck and swallow per second. Okay, so that's that set of slides. This one. And we'll go to the next set, some common breastfeeding situations that moms run into. But just kind of like we talked about, the more you can educate ahead of time, the more smoothly things are going to go. So really helping moms know where to get information when they're at home can be really helpful if they're not calling and asking you the questions. So like that first little anatomy and physiology slide show that we went through, you know, the hormonal control of breastfeeding is where it all starts. The prolactin says, all right, let's produce some milk. And the oxytocin makes the milk get let down. And then the feedback inhibitor of lactation is what builds up in milk inside the breast to say, hey, we're full, stop, don't make any more. And that is how, in the end, when you want to wean, that hormone's in there to say, no more, we're done. But it can build up inappropriately if you're not emptying the breast frequently. So, you know, just like with the baby friendly, our goal for the AP is that healthy newborns should all breastfeed within the first hour of life. That really helps mom and baby feel more comfortable, because if you get that first feed under your belt, you're like, all right, we know what we're doing. That one went well. We feel really good. It helps that baby too, because being skin to skin, just a good temperature regulation, and everybody will feel much more comfortable. So when we see the newborns in follow-up, we want to make sure they're feeding about 8 to 12 times per day. And sometimes the moms will report that they just feel like they're nursing continuously, and that is totally fine to start with, because that's how the milk supply is going to get increased. And then a feed can sometimes last 30 to 40 minutes, or they can feed every 30 to 40 minutes and usually about 10 minutes. But that should usually space out, and usually babies tend to have the cluster feeding in the evening. So kind of sad because mom's getting really tired, but that's the most important time because prolactin levels are higher overnight initially too. So that's why those nighttime feeds can be really important for getting breastfeeding established, because if moms are not taking advantage of the natural increase in the prolactin overnight, then they're going to have a harder time getting that breast milk supply up. So there's several different infant styles of feeders. So you've got the Barracuda, who's just like going crazy, gets excited, and is just energized the whole time. And then you've got the almost Barracuda, who's excited, but he's just not really very good. So he's impatient, because it does take 30 seconds to a minute for the milk to start flowing once the breast starts getting stimulated. So that one takes a little bit more time for the moms. You got the procrastinator, who just will hang out, not doing anything until the milk starts flowing. But a lot of times that's okay, because it's good enough if the baby is on the breast, even just hanging out, that's going to be enough stimulation for the mom to have the prolactin and oxytocin, everything start releasing to get that milk letdown reflex. And then you've got the slow feeder and then the protracted feeder. And the protracted feeders are the ones that drive moms the craziest, because they'll just nurse and then hang out and then nurse again. So then mom feels like they're a human pacifier. And so then you just do your best to let her, hope that she can hang in there until the baby matures a little bit. So all these infant cues are really important for parents to recognize from the beginning, signs of hunger, so you can catch the baby earlier when they start rooting, sucking around, making sounds and putting their hands in their mouth. And just really when they start waking up, kind of take notice of these things, because they're going to want to feed, and you don't want to wait until they're crying. You want to wait and get the feed started while they're still calm and just starting to get hungry. And if the infant's waking up to feed, that's great. But if they're not, they're going more than 3 or 4 hours overnight, then they need to be woken up to feed to begin with. Once they're gaining weight well, if they start sleeping longer, that's totally fine. All right, so we really want to keep the infants and babies together. So our job is to help the moms with their positioning and attachment, encourage that rooming in and feeding on demand. So the sooner you get moms and babies to feel comfortable with their schedule and their new routine, the more successful they're going to be. It's really important to educate moms about the normal volume of colostrum. There's only, an average of 45 cc's of colostrum in the first day, but that's all the baby needs. It's going to coat the gut. It's going to be all those good immunoglobulins that they're getting. The colostrum is a stimulant, so it's going to help pass that meconium too. And so, you just have to let moms know you just shouldn't expect a lot. Reaffirm that weight loss is totally fine in the first 24 hours. That's to be expected. And make sure they understand only one stool and one wet diaper is what we expect in the first day, with the increase according to days of life from there on. And we really want to make sure they're educated, and that we don't want to do the supplementation, because that's going to mess up the barrier that the colostrum is providing for the gut. And then our most important thing is when they go home, make sure that we get to see them 2 or 3 days later, because days 3 and 4 of life are when all the problems are going to start happening with the bilirubin and the dehydration and the feeding problems. So the colostrum's got also the neutrophils, that's going to get the right bacteria in your gut. Got the phagocytosis, chemotaxis. It's really all so helpful for the baby's gut. The small volumes like we talked about, so the feeding's less than 2 teaspoons of feed per day, and it does increase on the second day and continues increasing from there on. But the colostrum is really good, so we can get rid of that bilirubin, and then the more you feed, the more the colostrum is going to increase, and then the more you start getting to that transitional milk when the breasts are stimulated. Once you have the milk come in, and that's like the 3 to 5 days of life, you've got the fore milk, which is the higher volume but lower fat, and then you've got the hind milk, which is the low volume, high fat. So that's why you really want to make sure that each breast gets emptied before you move to the next side. Because if you just get a lot of the fore milk, it's going to make babies gassier a lot of times, and they'll get lower they'll have more frequent stools. So you really want to make sure you get all that fat out of the breast before they go to the second side. So that you can reassure moms that their babies are gaining weight well, so the baby's content after the feeds. Now that one you kind of take it with a little bit of grain of salt, because a baby who's not gaining weight well is going to maybe look like they're content because all they want to do is sleep because they're anorexic. But if they're gaining weight well, then you can reassure mom. If they're content after the feed, then you know they're good. If you're hearing them swallow during the feed, that's good. If the mom's seeing milk drip out of the left side when they're feeding on the right side, then that's reassuring as well. And you see some milk in the mom and the baby's mouth after the feeds. If mom's nipples are not sore, then that's a reassuring sign as well. If you're having, and this says 3+ stools after day 1, but as a general rule, we say 1 stool on the first day, 2 on the second day, and then 3+ from here on out until the breastfeeding is really going well. At 6 weeks of age, the milk, it can be so absorbed that they're not frequent stools, like maybe even 10 days or so. But if they're gaining weight, that's fine. And if the milk is in, then we expect to not see weight loss after that point. So that's between days 3 and 5. Mom this is her second baby, the baby's probably going to stop losing weight after day 3. But the first baby, it may take to day 5. And then hopefully moms are going to start noticing the difference that the breasts are not feeling as full after they've fed. So once the milk is in, you've got this urine output that's increased to 6 per day, many stools that are yellow and seedy. They should all be changed by day 5. And the breasts, they're going to feel larger and firmer and heavier. And some moms will feel the letdown with the little tingling sensation when the breast milk is let down. Some moms never do, and it's totally fine if they don't. But it is helpful when they do, because then they can feel like, okay, now I know that their milk is there. And then if they're leaking between feeds too, they will know that as well. So you can see the average milk intake at 1 month is about 800 mLs, but the range is huge. So that's how moms are able to produce enough milk for twins if they need to. 3 might be pushing it a little bit, but the breast will make as much milk as is being emptied. They'll keep resupplying. The average weight loss is 7% at 3 days, but our goal is less than 10%. And then we want to keep seeing the weight gain of about 1/2 ounce to 1 ounce per day to at least 2 months of life. We want them to regain birth weight by day 10, but definitely by day 14 is our latest. We want the 3 stools per day for the first 4 to 6 weeks, and then the stools can taper off and go every 10 days as long as the baby is gaining weight well. And so this is just average weight gain table for babies. You see it just goes down from an average of 30 grams per day to less than 10 by the time they're 1. So perception of insufficient milk supply, we talked about earlier, is a really common reason that moms stop breastfeeding. So they just really get nervous because they can't see it, and unless they're really trusting that those stools are all they need to see, they just really want that. They want to see the milk, see what's going on in their babies. But truly only about 5% of women will not make enough milk. So it's really important. Oh, too many touches. Okay. So it's really important that moms are educated about normal breastfeeding behaviors and patterns, and that it's really good that they know that it's normal for the baby to cluster feed, and it doesn't mean that there's anything wrong with the baby or with their milk. It's just that stimulation that they need. But when they're having growth spurts, the baby is going to want to feed a lot more often, because that's how the breasts are going to make the more milk that the baby needs to grow. It can be frustrating for parents because they see, oh, I give them a bottle and they eat so much more easily from it, and that can make them feel like they're doing something wrong. But in the long run, if a baby's nursing well, by the time they're 2 or 3 months old, they might be able to nurse in 5 or 10 minutes. And so it's going to get faster. It just takes a little bit of time to get there. And some moms are good at expressing milk, but some moms are not as good. So hand expression can be very helpful for those moms, but pumping is certainly useful for those who are going back to work or to school. Moms who don't feel the letdown, that can be really that can throw them off, because if they can't feel that the milk is in, then they just need to then look at the infant's mouth and see. And the infants are fussy, they get colic, so you need to reassure if the baby's gaining weight and the fussiness is there. That's just unfortunate, but totally normal. So keep on feeding. To make sure they understand all the things that we're looking at that make us reassured that what they're doing is perfect. So if if the mom is worried about decreased milk supply, then you want to make sure that you look for any reasons that would be a problem. If there really is a problem, are the mom and baby separate? Well, then we just have to work on pumping and getting mom's supply up. Are they feeding too long? Are they going too long between feeds, which we know a lot of our families do because they just get overwhelmed. There's too much else going on in the house. They're not really keeping track. They don't realize that when we say to feed every 2 to 3 hours, that's 2 hours from the start of one feed to the start of the next. Because if a feed takes kind of an hour, then they could easily only be doing 6 feeds a day instead of getting the numbers we want in there. If they're not latching well, or if they're just using the pacifier to hold off the baby till the next feed, then that can also increase their supply. And prematurity certainly can affect the supply too, because the infants are not going to be as mature. They're not going to latch and suckle as well and as effectively. If moms are giving formula, that's certainly going to decrease the supply because then the babies are not going to be as interested in nursing frequently enough. If moms are stressed or having any pain, that's going to be a negative reactor for milk supply as well. And always think about, is mom taking any medications that are going to affect her supply? The combination oral contraceptives, all those studies were really done when we used the high dose estrogen. So with the lower dose, it's more of a theoretical risk that the estrogen is going to decrease the milk supply. But since we have plenty of progesterone only and other non-estrogen birth control options, we prefer to just do that just to be on the safe side. If moms really are having milk supply, you always do need to think about these other reasons. Is she having hypothyroidism? Does she have PCOS? Because we do see that a good bit. Did she have breast surgery that interfered with the expression of the milk? Does she have breast hypoplasia? Does she have Sheehan syndrome after birth? Does she have retained placenta? Because if the progesterone level doesn't drop down, the milk's not going to come out. So that's got to be something that has to be taken care of. So when we're looking at growth, when we see those newborn follow-ups, we want to just check the weight, see how much down they are from their birth weight. We know there's a problem if they're losing more than 10%. We know there's a problem if they're not gained, they're back to birth weight by 2 weeks of age. And if we're not seeing that 20 grams per day between 2 weeks and 3 months of age. If infants aren't good feeders, that can certainly have problems with the milk. So then you need to do a good oral exam on the infant to see if there's a problem that we need to be working on. If they have anything like heart disease, that's going to make them need more than what a typical infant does. So they may need some supplementation. If they've got any food allergy, which luckily is pretty rare in the infants, or if they have reflux or pyloric stenosis, those can all cause problems too, but not as often a problem in the term infants. So always want to do that good follow-up for the management of slow weight gain, and take mom's history, see, did she notice that her breast got enlarged during pregnancy? Because if she didn't, then, well, there you go, there's your answer right there. She is one of the 5% who really is not going to be able to make enough milk. Any problems during the birth history? What's going on at home? Are there any stressors? Has the mom been sick? Has the infant been sick? Just try to get as good a history as they can give you. So when you're doing the exam, you want to look at mom's breasts and nipples, look at because if she's got inverted nipples or flat nipples, that could be a problem that's contributing to the baby's poor feeding, that you want to address that. Look at the infant. You want to see, does he have a cleft palate? Does he have tongue tie? Does he have just uncoordinated suck and the jaw is not moving appropriately? Any other congenital anomalies? Just like we talked about, the positioning in the latch and all those good things, because you just want to make sure those are all optimized, that mom is feeling as good as she can. The first thing we always do is just feed more frequently, and let's see you again in 2 days and see if that's made enough of a difference. Mom's going to express, hand pump to build up the supply as well. The more she empties, the more she's going to have increased supply. And then obviously if mom or baby are sick, treat them. And then only supplement when it's necessary. And if you're going to supplement, ideally you can start with expressed breast milk if the baby's not able to get enough out from the breast. So maybe mom can pump enough and start with that. If she cannot get enough milk out, then that's when we do the formula. And just try to do a small amount to start with, 1 to 2 ounces after each feed, but encourage that mom is still putting the baby to the breast so that you can keep getting stimulated as well. And then keep following the baby every 2 to 4 days, making sure they're gaining weight until they're gaining at least 20 grams per day. And then it's fine to just do weekly visits until they're above birth weight and following a consistent curve. So, you know, don't stop as soon as they get the 20 grams per day, because you might want at least one more visit to make sure that it's holding as a continuous pattern. And sometimes moms might want to talk about if they need a galactagogue to increase their milk production. Reglan is one that can be used. Domperidone is not available in the US, but it seems to be a good galactagogue that they use more in Canada. And then there's so many different herbal supplements that you can find at Target or any of the drugstores with the Blessed Thistle, and they have all these teas, and some of those can help mom. None of them have been studied to show to be super effective, but I mean, a lot of it is also just that moms feel like they're doing something to help, and just that real extra relaxation can be enough of a help to get things going in the right direction. So sore nipples can be kind of common for moms, but you just want it to be not overwhelmingly sore, because that bad thing is once they're sore, it's like a sore muscle. It can take 3 or 4 days to get better. So you need to figure out how to help moms work through it to begin with and try to avoid it as much as possible. But if they're sore beyond the first week, then it's not normal. Positioning and poor latch are the most common problems of moms having sore nipples. You can also think about yeast infections or mastitis, because that's certainly going to make mom uncomfortable. And if moms are sore, then that's going to interfere with their milk supply, because that pain is going to inhibit the letdown reflex, and then the feedback inhibitor of lactation will build up and cause problems. So if moms have inverted nipples, truly, when you hold the breast, then holding on the areola is going to show the nipple retracted. Sometimes as babies start feeding more frequently, the elasticity will improve in the nipple, and the baby will have something to grasp onto. If you don't have good luck with using a pump or syringe to draw the nipple out prior to a feed, you can try some of the little their little breast shells that I'll show a picture of in a minute, and those can just give the baby something to hold on to while the feed is getting started. And then once the milk is flowing, you can often remove those. So it's kind of the same thing, making sure the baby's in the right spot. Afterwards, to treat the mom, you can put some breast milk and let the nipples air dry, and that can help. And then put some lanolin on top of the breast too, because that can be soothing to the mom, and it's totally fine for the baby. Make sure she's not using any harsh soaps, and she can treat her pain with Tylenol and ibuprofen. If the mom is really having trouble and she's got dry, cracked nipples, she can start feeding on the side that's not as affected, and then once the milk's flowing, switch over, because once the milk is flowing, the baby's not going to be as aggressive with their suckling, and then that can let the sides not get uneven production, because since it is under local control, moms can totally breastfeed on one side only if the baby's not stimulating the sides equally. And so it's common for moms to complain that one side makes more milk than the other side. And they can correct that if they want to, but just by trying to focus on the side that's producing less, or they can just go with it, because as long as the baby's gaining weight, it doesn't really matter. And then the nipple shield is what you can use that can help a little bit. Make sure the baby doesn't have tongue tie, because if the baby's tongue tie, certainly mom's going to get pinched and that will make her feel uncomfortable. Okay, it's just a little summary. Okay. All right. And this is just a picture of the nipple shields that moms can wear if they either have flat nipples or sore nipples. That gives baby something to grasp onto, and then it just makes everybody more comfortable, and hopefully you only need to use them for 3 or 4 days.
Where do you get them?
Target, Walmart, wherever, they're like $5 to $10.
So someone has like,
They could use that. So it just kind of gives you a little bit of protection. And the main thing is that they don't use it too long, because you can have decreased supply if you use these, because you aren't getting as much of the skin touched touched by the baby, but if you put it on to get the feed started and then pull it off, put the baby back on, then that's usually the best way to use them. But yeah, and they come in all different sizes too, because all moms have different size nipples. So there's some that are small, some that are big. So she can just come and check out which ones. Mandela, of course, has tons of different options to use. Okay. There's another set of slides, but we won't go through that because there's too much. When you're checking for tongue tie, there's this official tool you can use, the Hazel-Baker assessment tool, and you look at the appearance of the tongue and the function of the tongue. And the appearance is a good one to use because it's got really good reliability between different people. But the function ones, most people say just use the first three because the rest of them are just not reliable between two people. We might all have different scores. So this just first looks at the shape of the tongue when the infant's trying to move their tongue up. How elastic is the frenulum? How long is the frenulum? Where does the frenulum attach? And again, where does it attach to the frenulum to the tongue and frenulum to the alveolar ridge? And then the function, you're just looking at how much does the tongue move, how much does it lift up and sideways, and then how far does it extend. And when you're looking at these, this will help you decide, does the baby have tongue tie that needs frenulotomy, or are we fine and we can keep going? The latch score is another objective measure you can look at to see if things are going well or if they need extra help. And the mnemonic is just for the latch, the audible swallowing, for the type of nipple the mom has, for the comfort of the mom, and how much help is required. So everything's just a 0, 1, or 2. And if you score less than a 7, then you need more help. And you're probably going to figure this out without going through these, but it's just a nice little objective thing. Okay, got a few questions, and then if we have time, we'll try to play a Kahoot. So a 26-year-old G1P0 has a spontaneous vaginal delivery after an uncomplicated pregnancy. She puts the baby directly on her mom's chest to help initiate breastfeeding. Which of the following combinations of hormonal changes helped to facilitate breastfeeding? Since y'all are here, y'all get to choose. A, yes, very good. So that decreased progesterone is the main thing, and those other two need to go up. So the decreased progesterone helps to start the lactation, and you got to have the increased prolactin to maintain it and start it, and the oxytocin is for the letdown. All right, next one, a 35-year-old mother is interested in breastfeeding. Unfortunately, she's on several medications and was wondering if she should have any medication changes before starting. She takes fluoxetine, a decongestant nasal spray, naproxen, insulin, captopril, and loratadine. Which suggestion will you make to the patient? And this one you may or may not know, since we don't manage mother's medications, but it's good just to be aware of where to find it. So you want to see if you can get the fluoxetine changed to paroxetine, because that's going to make its way less into the breast milk. The fluoxetine can get into the breast milk and cause irritability and fussing and sleeping disorders, feeding disorder, and slow weight gain. So since there are other good options that don't get into the breast milk, like paroxetine, we would prefer that overall. Captopril is totally fine, but you wouldn't want to change that one to atenolol because it can get into the breast milk and cause this cyanosis in the bradycardia. Insulin is fine because it doesn't go across, it's too big, and loratadine is fine too. Doesn't cause any side effects. So here's where you can find the drug information if you can't remember what's safe to use, the drugs and lactation database, and you can just search whatever medicine you want to put in there to see if it's okay, and it gives more information than you could ever want to know, but it will give you a little summary that says, okay, this medicine either is not absorbed at all into the breast milk, or once it's in the breast milk, is not absorbed at all into the stomach, or if it is, does it cross the blood-brain barrier, how much gets into it, and how much does it affect the baby? Because it takes about 7 months for infants to have the same or a similar drug handling system to adults. So I think kind of a general rule I came across was if you find the half-life is 2 hours, then, or whatever it is 5 times the half-life is how you should decide how long, if the medicine is, and if the mom's taking the medicine and it's going to get into the breast milk and affect the baby, how long moms would need to pump and dump would be 5 times the half-life of the drug. So if it's a 2-hour half-life, then mom would need to pump and dump for 10 hours if it was just a temporary drug that she was taking. But hopefully she wouldn't have to do that because that's a lot of trouble. All right. First time mother presents to your office with her daughter for their first well child visit. She's read many books about child health and nutrition, is wondering what she can do in the first year of life to ensure that her baby remains healthy. She wants to know if there should be any dietary supplements in addition to breastfeeding. What recommendations do you give? What'd you say? B?
B.
D, yes. Like I can't hear over here. Vitamin D, yes. As you see, we all do. We get the vitamin D for everybody. So unless you're premature, we don't do polyvisol, we don't do trivisol, we don't do anything, just the vitamin D for everybody. Okay. 6-day-old baby is brought in because he's got yellow skin. He was born at 34 weeks. His labor and delivery were uncomplicated. He has had no postnatal complications. His neonatal screening was normal. Sleeps often and breastfeeds about 4 times per day. Liver and spleen are non-palpable, and his bilirubin is 17. Which of the following is the most likely cause of the patient's symptoms? Yep, because the problem is that he's only feeding 4 times a day, so he's not getting enough food in to get poop out, so that bilirubin is just getting recirculated and not good. So the first one, the decreased secretion of conjugated bilirubin by hepatocytes, is a cause of these rare things, the Roeder and Dubin-Johnson syndromes. The G6PD would cause hemolysis, and that wouldn't be an issue, or more, it's less likely to be the issue than the increased intrahepatic circulation. And the increased levels of beta-glucuronidase in mother's breast milk, that's the proposed cause of the breast milk jaundice that babies will have that last, 3 weeks or so, or longer, 3 months. And that's not due to increased, it's not due to decreased intake of breast milk, it's due to increased. And then babies who aren't feeding well are not going to have increased stools, they're going to have decreased. So just as y'all all know, decreased feeding can have fewer stools, decreased elimination, increased intrahepatic circulation. All right, last question. A 23-year-old comes to the prenatal clinic at 37 weeks. When you ask her if she's planning to breastfeed, she tells you she has not decided. She knows breastfeeding would be good, but is wondering if breastfeeding will benefit her in any way. Which of the following is a maternal benefit of breastfeeding? Dalton says, I don't know. A, yes, reduced risk of breast cancer. Yep. So, and the breastfeeding, the breast cancer reduced risk is for, it kind of increases the longer moms breastfeed, the more of the benefit they get. The breastfeeding after birth can prevent hemorrhage, but it's not related to postpartum thrombosis. And then, unfortunately, while moms are breastfeeding, their bone density goes down, but it does rebound and often to above where it was before. So initially, they do have decreased bone mineral density, and it's not any effect on cervical cancer. But some of the benefits for the moms are the decreased risk of breast cancer, the postpartum hemorrhage with blood loss, the increased post-pregnancy weight loss, and increased mother and infant bonding. And additionally, if moms are exclusively breastfeeding, they're going to have lactational amenorrhea, and so that means more natural child spacing. And then breastfeeding is a very inexpensive way for moms to feed her baby. So there are some good reasons to breastfeed for mom too. And then lactational amenorrhea is due to the high levels of prolactin preventing the release of the gonadotropin releasing hormone, which then decreases LH and FSH, which then decreases estrogen. So if you're not having the estrogen release, then you're going to suppress ovulation and menstruation. So if moms are exclusively breastfeeding for at least 6 months or up to 6 months, and they're not going longer than about 6 hours between feeds, then they shouldn't be fertile. All bets are off once they start going longer than that, because you don't have to have a first period before you get pregnant. All right, and then we just briefly talked about Sheehan syndrome, when you have the postpartum hemorrhage that then has electrotrophs cells die, so then you're not going to get the milk production, unfortunately, from the prolactin. And then there's lots of different websites for information on breastfeeding. So if you ever need more information, so many different sites: Stanford, the AAP, the Office for Women's Health, the First Droplets, and on and on and on. And I guess that took longer than I was hoping, so we don't get to play Kahoot, my favorite thing in the world. Oh, well, we'll do that quiz another time for fun. Okay, any questions you may have?
What's like the real answer to drinking alcohol?
So if you're going to drink alcohol, 1 drink and wait 2 hours. So for every drink you have, you need to wait 2 hours before you feed the baby.
So like if you had 2 drinks over a period of an hour, it's like 3 hours after that second one, I guess.
Probably so. I mean, and really, ideally, if mom is not having alcohol during the whole pregnancy, then she's going to feel the effects of the alcohol. And once she's no longer feeling the effects of the alcohol, then it's safe to feed the baby. So 2 hours is just kind of the general rule. But if you slam 2 down, yeah, you probably better wait 3 hours at least. And so if you're feeling any effects, just pump and dump if it's time to feed, and still feel the effects of the alcohol if you can't wait. But if you wait and the alcohol's gone from your blood, it's going to go from the milk too. So it's not like alcohol's just accumulating in the milk. It's still getting the blood flow, so it's going to get out of there too. Yeah. So that's why it's fine to drink, but just wait so you're not making a drunk baby. And alcohol can decrease the milk production as well. Like there's some things that float out there that say, oh, the wheat and the barley and the beer makes moms have increased milk production. Not really in studies. So.
I have a baby in the NICU right now who bit. The mom had cracked nipples, and he bit.
Oh.
And she felt it, and she thought you were supposed to power through. So she kept feeding the baby for 10 minutes. And then when she took the baby down, the baby had a bright red,
so much blood.
emesis. So they put an OG tube down and sucked out a bunch of frank blood, sent the baby here for a GI bleed, and then
oh my gosh.
Eventually, when someone looked at the mom, she had blood pouring from her nipple.
Poor mom. Yeah, so always warn about those teeth, and don't power through when there's pain. Take a little break. There's things you can do.
Yep.
Yes.
Like the moms that do want to keep breastfeeding because they're getting like older, is there a point where it's like, no, moms are good, and like aside from they could have.
Yeah, I mean, truly no. I mean, because the World Health Organization says to go until at least 2, and they do say at least 2. So that means if they're fine with you continuing beyond. But yeah, I mean, in America, it's hard if people do beyond that, because people just are like, what are you doing? Because at that point, it's not a nutritional thing anymore. It's just a comfort, and it's a closeness thing. So, you know, most of the time it's like, are you just, you know, do you just not want to be separated from the baby, or, I mean, because nobody's getting anything good out of that. They're not going to be nursing enough to be continuing to support mom's weight loss plan, and it can interfere a little bit with her fertility. But at the same time, moms can get pregnant while they're nursing, and then can continue nursing the first baby while they're getting ready to feed the second baby. But then when the second one comes along, you know, we've had some interesting ones in the hospital. You really need to make sure that that first one is the one who gets to nurse first. And then if you really still feel strongly that the second one has to nurse, then they can have a little snack when the first one's finished. But not dad and not the second one first. And yeah, it's the correct order for everything. Yeah. Any other questions?
So funny.
Oh my gosh. Anybody else have questions from afar?
You won't sign off.
What? I think no. All right, I'm leaving. So. Oh goodness. Oh, whoops. Where's I see the chats? There we go. Okay. Oh, that was that. Okay. How about almond milk, soy milk? So Dalton says neither almond milk or soy milk come from the breast. Oh, now I'm not even zooming anymore. Oh, I am still? Okay. I don't know. Now I can't see my questions anymore. Why do I see the NICU? This one? Okay. All right. So for the almond milk or soy milk, when you transition to milks at 12 months of age, the AAP doesn't recommend those because they can have increased levels of sugars in them, and you're not getting any nutritional benefit from those. So we recommend that you go to whole milk because it's got the vitamin D in it and it's got the higher fat that's going to be helpful for the babies. Well, it's helpful. So if you're not going to drink whole milk, we'd rather you not do the soy and almond. But for vegetarian parent, I mean, probably so. I mean, I guess maybe you'd rather that instead of no milk at all, but you just have to worry about where they're going to get the vitamin D and the calcium that they need. So then you might have to start thinking about, do you need a vitamin supplement? But we try to encourage families to avoid those. Just stick with simple water and regular milk. Okay, any other questions? Anybody wants to type in, turn off the microphone? Okay, all right.